Yeah. So sorry for the technical delay. Uh, what I was saying was DSDN. DSDN is double-stranded DNA, which is very specific for SLE. Then we have got loads of HLA. One of very famous is HLA-B27. Then we have got for rheumatoid arthritis and so on. ANA. ANA is anti-nuclear antibodies. Anti-nuclear antibodies, whenever it's positive, that means they are definitely dealing with a uh, AID, unless otherwise proved. But when it's positive in certain other hepatitis and other certain infections also, liver function and kidney function test and thyroid profile has to be done. Radiology, X-ray of that affected part, CT scan, MRI wherever is needed, 2D echo or 3D echo Doppler studies, and ophthalmic examination, perimetry, and fundoscopy. These are few of the drugs. I have, few of the investigations, and I have left urine routine, which is a very, very important thing. The urine routine is, in fact, the first investigation to be done, and then urine proteins and everything. Urine routine will cover everything. Then, what are my management goals? Suppose if I get a patient, what should be the goal of management? My dear friends, we are all born with different genetic characteristics. Okay, so we have no control over those genetic characteristics, but what we can control is the manner of the genetic expressions. So I can control if once the AID has started, I can control the intensity of that manifestation and how long will I have this manifestation, how fast I can heal. So it's up to me. So it's never an all or no phenomenon. It's never dependent only on drugs. So the goal of management is to ask the patient that you have brought the disease, you are responsible, and we are just going to help you as doctors. But with positive thought structure, we can be able to, may not be reversible, but at least bring the disease to a very primitive form or a very manageable limit. So for all homeopaths in general, the first thing foremost is at least reduce the symptoms and control the autoimmune process. Both are very well possible most of AIDs and with most of the homeopathic drugs. Number two is maintain the body's ability to fight the disease. Suppression of active and certain times you have to suppress active and progressive disease. You have no choice. Even if that suppression leads to something else, we know that. But then sometimes we have no choice. So homeopathy drugs are always better as compared to other systems if you are able to suppress a particular symptom or a group of symptoms. After the patient is stabilized, then I would aim is conservation, restoration of function in affected areas. Whichever function is lost, if I can conserve it or enhance it, then it will be much better. Gradual possible withdrawal of symptomatic drugs. Like suppose if steroids have started, it is my duty that slowly and steadily steroids plus methotrexate, so stop methotrexate and let steroids remain, then stop steroids and slowly taper off steroids if it is possible. So that's then I have to use lots and lots of auxiliary measures. So I should keep my drugs with me for a longer time and use more of placebos and use a lot of auxiliary therapy measures and use my homeopathic drugs only and only when I get definite symptom syndrome or indications to prescribe upon. And last is isotherapy, which we're going to discuss in depth again. So this is Dil Ki Seva Adil Se. So whenever an AID comes to me, any case comes to me, particularly when we're talking about AID, what do I do? Obviously, a detailed history is taken, whether it be a case of migraine, asthma, or rheumatoid arthritis. For me, I have to take the detailed history, but what I focus is on causation. That is ailments from, which we have already discussed in depth. If I get a reliable ailment from and I can correlate that ailment from with the disease, onset of the disease, then half of my drug selection is done. It's become so easy, at least to start the therapy. Then the onset of the disease. It was a sudden onset or a gradual onset. Modalities, obviously, symptoms, complete symptoms, the life space, the mental state before and after the disease. Like before the diagnosis of SLE and after the diagnosis of SLE, has the mental state changed? Before steroids and after receiving steroids, has the mental state changed? the physical generals and the alterations, past, personal, and family history. And ultimately, what I aim is to find the person in the patient. So today I'm seeing the patient, but I also want to find the person, the original person whose original mental state and the original physical generals before the disease. And I want to know the person, ailments from, and the disease. So if I have to give a constitutional remedy, it will be based on the person, or it can be based on the ailment from. And if I have to give a symptomatic drug, then it will be based on the disease symptom. If I'm able to do that, it's a successful case taking. So successful case taking is not only a one-day phenomenon. So the patient comes to you and you talk to the patient for about 10 minutes or 15 minutes or half an hour. No, it can be a month-long phenomenon. You can give an appointment, recurrent appointment, till you actually understand the patient well. It may take some time, and you may need to call the patient's relatives, the spouse, the children, the parents, and so on and so forth, and get their perspective of the patient as a person and a patient. That's very important. This most of us don't do. We only concentrate on ABCD symptoms, repertorize them, and start giving drugs and then fail. That's not the way to do. You may not give the constitutional therapy, but I should know that I'm dealing with an arsenic who has now presented in the form of, say, Nux vomica like symptoms. So the present symptomatology is Nux vomica, but basically, as a person, the patients are arsenic. This, as a homeopath, I can do that. And all those who are homeopaths, I believe everyone is homeopath. So you may be able to reverberate what I'm speaking. Particularly if you have attended a school, we always do this as far as a certain 1995 big polycrest remedies are concerned. We teach you mathematica as a person, as a patient, and the ailment from. The transformation of a person to a patient needs that ailment from. So I have to find the person in the patient. Then after they taking the entire history, what I do, I see the stage of the disease, whether the patient is in an emergency or a distressing acute symptom. So I first tackle that emergency or a distressing acute symptom. Second, it may be a chronic case, but a virgin case. Probably I have detected it. So please do not doubt your abilities to detect AID. You are doctors and trained doctors and skilled doctors. So if you are there, you also can detect an AID by investigations, by history and all. So then there will be a virgin case. A virgin case is one and no other therapy has been taken. So this gives you a very, very good chance to apply homeopathy to its fullest extent. Then you can have most of the cases which we have is number 3, already diagnosed and on one or more therapies, and then they've come to homeopathy after say 1 year or 2 years or 6 months, and then they want homeopathy. The doctor, I've been taking too many drugs, I'm not better, the disease is increasing, the complications are increasing, and now I'm come to you for some therapy. Thus, then you can have comorbidities, active comorbidities like diabetes and hypertension, hypothyroidism, and so on and so forth. But that is the biggest problem. Like a virgin case, a pure rheumatoid arthritis case, and rheumatoid arthritis with diabetes. So it's more difficult to manage. But not only diabetes, but their drugs, their clinical biochemical response of those drugs. All in all, we are not dealing with, like, suppose people come with 3 diseases also: rheumatoid arthritis, diabetes, and dyslipidemia, and plus their drugs. So they've drug diseases is also there, and 3 diseases also there. It becomes a great deal of effort on the part of homeopath to distinguish and deal with. I mean, you have to decide what to deal with first. Then we can have either steroid or immunosuppressant people, patients already on steroids or immunosuppressant, and that too, they may be dependent either on the steroids or immunosuppressant, or they may be resistant to those drugs, and that is the reason why they have come to you. But the drugs are still on. Like a person of rheumatoid arthritis has come to you with steroids and with methotrexate since a year, and they are not getting well, but still the remedy is on. How do you withdraw this? So you can have such patients. You do have such patients. And last is the complications of the disease, primary disease, which are the AID, the drugs for all the syndromes and the complications of both mixture. So these are the stages of disease, and I, as a homeopath, have to place myself mentally what am I going to do with this case? If I am not able to decide this, then, my dear friends, it would be a very great hassle. You are not competent enough to treat them. So, your competency lies in placing your role as a homeopath, as a healer in this jungle, juggernaut of the patient. So, homeopathic management, how do we do? This will be in the next lecture series. It's again extensive topic. A general management will be there, and then we'll come to specific drugs, specific diseases. If you have got any questions, please be free to ask. So I've got my interns also here sitting. If you also have got any questions, please ask. Now there can be two reasons. Either you have no questions, that means I've understood it fully well, or you have understood nothing. Well, sir, I joined late today and I don't understand exactly about today's class. So once you see the entire lecture, you will have the link. Vitiligo is autoimmune. Yes, Surabhi, sorry. Vitiligo is an autoimmune disease and we are going to talk about vitiligo. There are 100 autoimmune diseases, nearly 100, and of which we only speak about few. Only I'm not going to tell anything about vitiligo today. We are going to talk about vitiligo and psoriasis and pemphigus and rheumatoid arthritis and Hashimoto's thyroiditis and SLE and I don't know so many other names in the later lectures. But today I only wanted to tell you about overall what is an AID, autoimmune disease, the causes, the miasmatic assessment, and the history taken. Now, the management part is very important. So please don't miss that management part. How RBC indices will help? Sagar, RBC indices are very, very important. A disease called as pernicious anemia. Pernicious anemia is diagnosed how? By RBC indices. And pernicious anemia is an AID. So don't only go for rheumatoid arthritis or something. RBC indices gives a lot and lot of information. Psoriasis, how can we stage it? You will be able to, when we talk about psoriasis, we'll be able to tell you. I'll be telling you, man. So you said that you say all patients to have a job, but being a housewife is also a full-time job. Aditya Pandey, yes, it's a full-time job. But then many housewives also work outside, right? And then they are unable to cope up. And like they may not have family support system. Nowadays, urban husbands are helping their wives in the kitchen or making some things, but it's not true with everyone. So, and same way with our husbands also. Certain husbands are they work in the house and they will work outside. They have very little support from the wife. That also can be possible, right? If you have a CPR wife and the husband is say pulsatilla, then you have a big problem. The husband is likely to get such diseases. What is the scope of homeopathy in SLA and myositis? We are going to discuss in the next lecture. No? Tubercular miasma. I think I have elaborated quite. It's a transition miasm between SORA and organic miasm. Either psychotic, syphilitic. There, any symptoms is recurrent, changeable, and in the changeable in intensity, in the place, in the manner. That is called tubercular miasm. Salik Mohammad Khan, thank you very much. Is it necessary for us to advise every housewife to get a job? No, no, no. That is not the situation. My meaning was many people who are retired, they don't do any work. I'm not talking about housewives here. Housewife was one example. Second example is people who don't do work. They just sit and they while away time or just play with mobile and they seem to be very busy. There's a rubric in 1070 called fruitlessly busy. Busy fruitlessly. So you seem to be busy, but actually it's fruitless. So such people need to go and work. Once you're working properly, then basically your symptoms get reduced. So why are AIDs very much prevalent in recent years? Now, can autoimmune disease be prevented from passing next generation? Obviously, yes. We can prevent. How? I'll be explaining later. But is there anything else, your point of view? Well, recent years, the most recent thing is COVID and COVID vaccine, which I have seen. I may be wrong, but then I cannot be that wrong because we're seeing patients daily and day in and day out, and then we are correlating with it. Sir, will prognosis of AIT be difficult in strong syphilitic myasm? Yes. No, not family history is not. I mean, if there's a strong family history of syphilitic myasm in the family, that prognosis may not apply to the disease proper also. Before homeopaths, we also have a certain drug picture. Does this drug picture orientation doctor will give a correct? Yes, that is the reason why I told you drug as a person. Sorry, patient as a person and a patient as a uh, no. This patient who comes, how was he or she before the entire event took place? Today the patient is coming with symptoms. Today the patient has got that ailment from. Today the patient is taking drugs also. So all these have today. So today the patient is totally colored, what we call, or corrupted. But how was he or she before the entire event began? That's important for us. Please elaborate asthma. Why asthma? Asthma is not an autoimmune disease, it's an allergy. And there's a difference between allergy and autoimmune disease. Although they look same, but autoimmune disease is very, very deep. Allergy is very superficial. I'm not going to get, but asthma-like disorders, of course, I'm going to give a protocol about that. Rhinitis and chikungunya, Suparna, this is not my, I mean, today is not the topic for discussion of rhinitis, chikungunya, and asthma. How diet it will use in AID? I'm going to talk about diet and AID. I've already talked about certain dietary foods that instigate these AIDs. But the next lecture, in depth, which actually things we have to stop, and that I'm going to tell you. Can we manage type 1 diabetes homeopathy without giving insulin? That totally is case-based phenomena, but mostly no. Type 1 DM cannot be exclusively managed with homeopathy without external insulin. That's my experience. In autoimmune disease, we have to identify personality. Yes, yes, yes. Sir, as the mother is having psychotic miasm, can we prevent them from passing to baby? Yes, why not? Sir, basing on which personality, basing on which personality, we should describe the presenting picture or past. Based on which personality, we should prescribe the presenting picture. No, no, no. That is totally based on the patient, Harsha. If the patient has an acute symptomatology, like for example, a patient of rheumatoid arthritis is coming, they are not worried. They are worried that today my joint pain is too much. You decrease the joint pain, whatever you want to do. So I can't give the constitutional therapy. I have to first decrease the joint pain. So I have to see what the patient wants as of now. The personality part will come later on when I'm attempting to cure. Suppose if I want to, my patient is settled since past 3 years now. Since 3 years, he or she has not got any high attacks. Very settled. Not on any allopathic drugs also. That is the time when I would want that let me try to give a drug which will not bring on these attacks, future attacks. There I need the personality of the original personality of the person that before the starting of this event. Any more? Sir, but if we give constitutional drug to an AIDS patient and we are making his immune system strong, yes, that's true, but not always true. We can't always give constitutional therapy. Constitutional therapy has to be given only in stable patients. A. B. Once you give constitutional therapy, then it will follow laws of cure, Ehring's laws of cure. So you should have an evolutionary history for that. And once we give the constitutional therapy in the correct potency and dose, then the patient should not suppress the previous symptomatology. Like suppose if the patient had got, say, today the patient has come with psoriasis, full-blown psoriasis. Okay, you have settled the case. Now it's been 2 years. Case is fairly settled. Now you want that the psoriatic attacks should not go, should recur, number one. And second, psoriasis is not only a skin disease, but it affects the joints also. So we don't want the disease to spread to the joints. So what I would think of is a constitutional therapy, prescription. But suppose if that psoriasis patient had past history of excessive tinea, tinea corporis was there, and for somehow they had taken a lot of ointments and all, and it suppressed that ointments, I mean the tinea, and now the tinea is gone, psoriasis is in its place. So if we decrease, give the constitutional therapy, psoriasis will go, I mean, decrease, symptoms will go down, but that will come up, that tinea corporis. Then we cannot ask the patient, I mean, then the patient has no authority in suppressing the tinea. Otherwise, my entire prescription will go waste. I hope you understand. Number one. Second, we are now not in Hahnemannian era. We are in the era of Consumer Protection Act. So, if we don't ask the patient, I mean, we don't train the patient that, see, our homeopathic medicines are going to take out the old symptoms also that you have to bear, then possibly you may be in a legal dilemma. Patient will can sue you that, doctor, I had come to this doctor for psoriasis, and the psoriasis is okay taking place, but other skin disease has started. So he is culprit. Now, then what are you going to do? This has happened. No? Such cases have happened. So it is our duty to train the patient that what is the constitutional therapy. They don't know anything about that. Anti-miasma is when to prescribe. We are going to tell you about in the management part later on. When patient came after kidney transplant again, dialysis, what we think of? We think of management. We think that as I thought of an autoimmune disease to stop the progression, civilin always comes to my mind for slowing down progression. But as a deep remedy, sometimes I resist to use. Could you guide how and when to use and what can be other measures for slowing down the progression? Param, it is not only civilinum. There are lots of other nosodes and sarcodes. And I believe you have attended both my nosodes and sarcodes lectures. There extensively I have dealt with using nosodes. But now my management part is yet to come. So that we are going to discuss how to use nosodes in practice. How do autoimmune diseases differ in their mechanisms, and we are going to discuss that in the next lecture. We have two more lectures to go. No? So this was just a priming session, overall session. And now we are going to specifically focus on the management part, general management first and diseases later on. So ladies and gentlemen, thank you so much for joining. Okay. When a patient came after kidney transplant again, I have already answered this question. We have to think of many things. There's not a single homeopathic remedy after kidney transplant. I want to know what patient is going to, I mean, any symptom, because already after kidney transplant, patient for 3 years or more is on immunosuppressants, heavy immunosuppressants. So they are not going to come to you. And we have actually, I've taken a slide on whether homeopathic medicines really work in the presence of immunosuppressants. Because we are getting most of the cases in the presence of immunosuppressants only. The patient is in the already taking immunosuppressants, and in spite of that, he's asking or she's asking for homeopathic treatment. So, I, as a scientist, need to know whether my drugs are potent enough to act in the presence of an immunosuppressant. So that slide I'm going to discuss later on. Unfortunately, I could not get the time. Otherwise, I would discuss today. Same way with pregnancy. I mean, pregnancy has a totally different scenario of autoimmune disease. The same autoimmune disease in a non-pregnant state and in a pregnant state, they will behave differently, and homeopathic medications need to be given that way. So we are going to discuss that also. I don't know. I have so much to discuss, but no time is less. I think we need to increase one more lecture. So 3 is not enough. This one was preliminary session, priming session. The other 3 are very important because I'm going to actually discuss. I'll not discuss 100 cases, 100 diseases, but I have to discuss cases also. And then I have to discuss my failures also, why I fail in my home. Certain times I failed. So I have to tell you my failures and how I've corrected that failures. Because we are going to fail. It's not always, in all cases, we're going to succeed. So that's, I don't know how much I'm going to speak, but then let me see in 1.5, 2 years, 2 hours time, how much I can cover. Thank you so much. Meet you again in the next session. Till then, Enjoy your days. Good night. Take care.